This episode of the Bari Chronicles is proudly brought to you by Bariatric Support Australia.
Hi everybody, I'm Tash.
And I'm Damo.
And we are so excited to bring you this week's episode of the
Bari
Bari Chronicles. Damo, this week we are chatting with a friend of the Bari Chronicles, someone that we have loved talking with a number of times before, the one and only Dr. Terry Lynn.
Thanks for joining us. Dr. Terry Lynn, thank you so much for joining us today. It's awesome to have you on the Bari Chronicles again.
And thank you. It's my pleasure to be here.
So I was wondering if we could talk a little bit about menopause and perimenopause, especially in the weight loss surgery, bariatric surgery sphere, I suppose. We've been getting so many questions about it, and it's a topic that really isn't talked about very much.
Yeah, that's right. I think that the audience needs to understand just a couple of definitions. Technically, perimenopause is the time leading up to the menopause, and the menopause is technically 12 months after the last menstrual period, and then you are post-menopause after that. So perimenopause, the menopause, and post-menopause, and they're slightly different clinical symptoms and signs, but to understand that there is something very different about leading up to that menopause transition as opposed to some of the health concerns after the menopause transition. And the average age of the last menstrual period in Australian women is around 51 years of age. The perimenopause, so leading up to that final menstrual period, can occur up to 10 years before that last menstrual period. So any woman in their 40s, I'm very mindful that they could be perimenopausal. If a woman is having her last period before the age of 40, that would what we would call premature menopause, and that's something that is of significant concern. That's what we would call outside of normal limits. That would be a pathological diagnosis, and they need specialist care and follow up with premature menopause. Early menopause would be sort of 40 to 45, but peri is anywhere in those 40s and into the 50s, and then post-menopause is more than 12 months after that last menstrual period.
I'm definitely in that perimenopause time frame myself. I had a hysterectomy 3 years ago, so periods haven't been an issue, but I still have my ovaries. So it's been a strange time, because I'm definitely noticing some odd things happening to me.
It's not contagious, is it?
No, it is not contagious, silly man.
Well, this is what I think is can be very confusing for patients and the general public. Is there are some symptoms of the menopause transition that are really quite obvious. For example, changes in periods, and particularly stopping periods. But if, like yourself, Tash, you've had a hysterectomy, or some people might have had a uterine ablation or endometrial ablation, or have a Mirena, for example, where that is controlling their background hormonal changes and influences on their bleeding patterns, we might not see those obvious perimenopause and menopause symptoms. And some of the other list of symptoms, some of them again are very menopause specific, but for example, hot flushes would be happening sort of closer to that end of that transition rather than the earlier of the transition. And then there's all sorts of potential symptoms in amongst all of that, including impacts on mood and sleep, libido, what we call the genito-urinary syndrome of menopause. And where patients might have any of those symptoms is depending on where they are on that sort of scale between premenopause, perimenopause, menopause, and postmenopause. So it's very individual, and it definitely lasts years. That's the other thing, is a lot of women I see will say, how long is this going to last? In general, it's 5 to 7 years. Some women less, some women more. And in regards to severity of symptoms, it's really about a rule of threes, where a 30% of women might have very mild symptoms, not particularly concerned. A third of women will have moderate to troubling symptoms, and a third of women will have what we call severe symptoms. And some women actually continue to have symptoms, a very small percentage, but some women continue to have symptoms beyond that 5 to 7 years as well.
Wow. Aren't we so fortunate and lucky to be women?
Absolutely.
It's just the gift that keeps on giving. I mean, for me, obviously, to have had a hysterectomy, already I was already experiencing horrific. I'd had horrific cycles. I'd had an ablation, and I was still bleeding very, very heavily. And we found out post my hysterectomy that I had adenomyosis.
Yeah.
So we didn't know prior. We just knew that it was a horrible situation to have been in. But what I suppose I hadn't really counted on was my ovaries still giving me grief when I would be ovulating after my hysterectomy. I never even considered that I would still have pain. I didn't consider really, I suppose, what menopause was going to look like, or how I would know, or what would happen at all. I just sort of thought, well, yay, at least I'm not bleeding for 3 weeks out of every 4. So yay for that. But knowing when menopause, like perimenopause, all of these sorts of things, I just had no idea. I just did not know.
It's like when you were talking at the beginning, it isn't talked about. I think that it is getting a little bit more airplay now, which is great. And I think that that's because there's a lot of women in our age group, Tash, that are in the media and are bringing that attention to actually have these discussions. But I also think that some of the symptoms, I can just think of, there's a symptom score chart, a validated symptom score chart called the Australian Menopause Society has that on their website, and it's got about 10, 15 different symptoms. But what I do find is that because there are so many potential symptoms of the menopause, perimenopause, and then people are very individual, each woman's journey is quite different.
So it's just really important that, and how do we access appropriate care for when we're starting to experience these sorts of questions, I suppose?
Yeah, I think that your primary healthcare practitioner is the best person to go to, because although there's a lot of a cluster of symptoms and potential signs in the menopause, perimenopause, a good primary healthcare practitioner will get a better sense of, well, how much of these are in this little pocket called perimenopause, or how much of it could be something else. So there are some what I would say very specific symptoms of menopause, which is the change in periods and the hot flushes, but that's only 2 out of the 15 that could be affecting people. But then there is an overlap of menopause, perimenopause symptoms with other medical conditions, and that's where a really good primary healthcare professional can have a holistic assessment and try and find out what's going on, and to also know that more than one thing can be happening at the same time. And I'll give you an example. One of the early changes from a perimenopause point of view can be an impact on a patient's mood, and so this can be due to the menopause, but it may also be a separate clinical diagnosis from a mood point of view. And a good primary healthcare practitioner will be able to get a sense of how much is what, and talk about treatment options as well.
Wow. So it could be really sort of detrimental, I suppose, to someone to just sort of try and guess what they're experiencing.
I think so, because it's so broad. We do have these validated symptom score charts, but some of the more, I guess, social media, popular websites are overplaying some of the symptoms as being purely menopause, whereas the reality is there can be so many things. So if we think about the typical, female in their 40s to mid 50s, they're often, that's what we call the sandwich generation. They're often caring for their own children plus their elderly parents. They're often working mums. They're carrying a lot of balls. They're also having lots of changes going on, and it'd be hard to say that symptoms of tiredness or brain fog or interrupted sleep are purely from a menopause point of view. We need to take a broader, more holistic view of things. But also, I think that things are changing in regards to management options of the perimenopause, and certainly there was a decline away from hormone replacement therapy in the early 2000s. It's no longer called hormone replacement therapy. It's actually called menopause hormone treatment. And the reason there was a deflection away from prescription of hormones in the 2000s was a global study called the Women's Health Initiative, which was concerned about some of the side effects of hormone replacement. A lot of the concerns have been shown to be related to the type of estrogen and progesterone, the age that people were when they were taking the medication. And we've now got better advice based on research to say that some of the concerns were not as significant as what we once thought, particularly with our better, newer hormone management options.
Okay. Well, that's good to know.
It's been a slow process to get there, though, hasn't it?
It has.
20 years.
Yeah, that's right. Yes, it was. I remember when that study came out, and there was a huge decline in people taking any sort of hormone replacement, and then there was a sort of a lack of effective non-hormonal treatments. I think today we actually, even though I think we don't talk about the menopause transition enough, I feel that we're in a much better position because we have better understanding of non-hormonal treatment options than we have the hormonal treatment options, and then in amongst all of that is the lifestyle advice as well.
So in the bariatric metabolic space, is it more complicated to potentially get an accurate diagnosis? Because I'm just sort of thinking for myself, and I know that some of the symptoms that I've had could definitely be that some of my vitamins are out.
Yes.
Or like I'm deficient in something or another, and so that's why that's happening. And I know for me, I made that assumption for quite a while, and it wasn't until my GP said to me, "Hey, Tash, maybe we should look at your hormones as well," that I went, "Oh, okay. Like, could it really be that like already?" And he said, "Yeah,
that's right. Yeah, I agree. I think that, in general, all GPs and primary healthcare professionals should be asking that question from any woman from the age of 40 and above. And I think that we haven't been asking proactively. And then when anyone in their 40s is coming with potential symptoms, we might be applying it to something else. And so, yes, that's where I think that the question needs to be asked along with what other things, such as, example, changes in thyroid function or stress or sleep, or, like you said, in the bariatric community, in particular, multivitamin and mineral deficiencies. That's right.
Yeah. Okay. Do you want to ask Dr. Terry some of our questions that we've had?
Yeah. So one of the questions that we had come in, what is the best approach to managing weight gain when it's caused by hormonal changes rather than just calorie intake? Yeah. So this is someone who's had their weight loss surgery and
they're in that menopausal age.
Yeah. So I think let's try and do a little bit of myth busting here. So I think it's important to know that men and women gain weight in middle age. And so we talk about menopause-related weight gain. Well, men also gain weight in that same middle age bracket as well. The difference, and I guess, why do we gain weight in our middle age? It is a aging, reason. So as we age, we're actually decreasing how much energy we use, how active we are, and some changing body composition with a slow reduction in muscle mass, which contributes to our basal metabolic rate. So we gain weight, whether we're male or female, through the middle years.
Very good.
The role of menopause, if we think of some of those perimenopause situations, so these can be very large swings in both the estrogen and the progesterone, and this is where we might know significant fluid shifts. So some of those hormones are related to fluid retention, so you might notice more swings in regards to a couple of kilograms of fluid retention prior to a period, and then noticing that those 2 kilograms go after a period. But in the post-menopause, so that is, a very low estrogen environment, the lack of estrogen means that if there's any weight gain, the extra fat gain is around the middle, as opposed to being, over the hips, thighs, and buttocks. So all middle-aged adults, are at risk of gaining weight because of those age-related changes. And then if you have a lack of estrogen, that weight gain will be more around the middle than around the bottom half of the body. Okay. And it's that middle fat tissue gain, that what we call that visceral adipose tissue, that is the increased risk from a metabolic health point of view: type 2 diabetes, fatty liver disease, high blood pressure, cardiovascular disease, etc.
Wow, it's amazing that different things affect where the weight will come back on, or the areas that will collect that adipose tissue.
Yeah, absolutely.
So how do we, or can we, target those areas? Because that is another thing that's really commonly asked, that the fat that goes on around the middle, even with a bariatric metabolic procedure, oftentimes people are saying that is very hard to lose, that particular tissue. Is there a way that we know of that is proven to assist with the reduction in those particular areas? Or
it's very hard to do what we call spot reduction.
Yes.
And so a lot of this, ultimately is your genetics in regards to, before the perimenopause, what sort of body shape were you? We talk about a gynoid body shape, which is more of a pear shape, or an android body shape, which is more of an apple shape. So they've got some baseline genetics, and then that lack of estrogen is tending to turn someone who was a pear shape into an apple shape. So in general, it's still about the balancing from a weight control point of view. There isn't anything in particular that can target fat loss around the middle. Watch this space though, because some of the newer medications are looking specifically at targeting more of that visceral adipose tissue, but there's not any that I can particularly talk about today. But certainly there is some potential exciting research to not necessarily lose weight. There was one that actually just seemed to move the fat tissue from in amongst the organs to underneath the skin. And so we know that fat under the skin is a storage fat, and it's not associated with increased metabolic risk, but it is what we call excess, abnormally stored fat tissue around the organs and within the organs. That is the risk there. So, we are still very weight focused in the medical profession, but some of these medications may be, look, you're not going to lose weight on these medications, but it's going to move it from the middle to the outside and therefore reduce your risk.
Which is wonderful.
Yes. I tell you what though, I still think it would be very challenging for a lot of people to be told that this medication is helping their health, but they're not seing the number on the scales go down. I think we're still very focused on that. So it is hard. Yeah.
I think that whole conversation is just hard. It really is.
Yes.
To know that to know that we're healthier, but haven't necessarily achieved whatever the ideal was.
That's right.
Or the
Yep.
yeah.
And as you know, that conversation is changing. It's going to take a lot of years to really get that out, and reverse 50 plus years of talking about healthy weight ranges and ideal body weights and
BMIs and all the maddening things.
Yes.
Yeah. We are eagerly anticipating that day, but we know that there's a lot of work to do.
I mean, we've had people that have sort of said, well, why would I have surgery if the scales aren't going to move? If I'm not going to lose all this weight.
X amount of
and like for me, I had my surgery because I was going to die from type 2 diabetes. It wasn't, I was fairly happy with how I looked and the weight that I was at, but not the added issues that were happening. But I also do understand people's feelings on wanting those scales to move. But yeah, it's just a very hard conversation.
So obviously in this particular time in our lives, we just can expect that the scales will increase or are more likely to increase.
Yeah, I think we're battling it. We're definitely battling it. Doesn't mean it's inevitable. No, it doesn't. But I also think that we need to have some sort of body image acceptance that our bodies are aging and then they do change. But what I'd be focusing on is more about those health gains in regards to preserving muscle mass, so particularly healthy aging and being strong. And strong is independent of the number on the scales. So particularly, trying to maintain our muscle mass, but also make that muscle more functional, so that in our older years that we're less vulnerable to falls, and that we can keep our independence and our quality of life. So it starts now. It starts in what you do in your late 40s and early 50s is going to determine how you are in your 70s.
I have definitely increased my strength, not a crazy amount, but increased my strength training and started doing some exercises that focus on maintaining mobility as I age, because I've identified that building muscle is far more difficult for me now than what it was even 5 years ago.
That's right. So mobility, balance is really important, muscle building, but also that strength training that you're doing, Tash, is really important for your bone health as well. So we know that post-menopause health concerns with that lack of estrogen is certainly in regards to osteoporosis risk, more so for females as well. So any sort of strength-based training that's putting some sort of strain on your muscles, pulling on those bones is really helpful for bone health.
That was actually another question that a member did ask. They asked, why is it important to monitor bone health during this particular phase of life, and also obviously as bariatric people, and should we be looking at DEXA scans? Should we be doing things like that just to monitor things or Yeah,
so I've got sort of 3 levels of recommendations. One is that if there are a number of risk factors in regards to increased risk of osteoporosis, so it includes family history. It includes some conditions like high thyroid, so hypothyroidism, regular or excessive use of steroids, other conditions such as celiac disease, or anything that may reduce the absorption of nutrients, and that also includes bariatric surgery. So certainly if I saw someone who had bariatric surgery, I'd go through all of the different risks there and work out whether they are at higher risk, and recommend bone mineral density as at least as a baseline, and then depending on that, whether it needs further reviews. And certainly some of the international recommendations from a metabolic bariatric surgery point of view some of the guidelines do include a baseline DEXA, but in Australia it's not bulk billed unless you meet certain criteria. It's not a particularly expensive investigation. I think it's around $100. But if you meet certain criteria, then it is bulk billed. So certainly anyone who has any of those extra risk factors, and that includes post-menopausal females, people who've undergone bariatric surgery, so particularly the males in bariatric surgery, and to know that anyone over the age of 70 can access a bulk billed DEXA scan. So in Australia, our government will pay for DEXA scans over 70s, but anyone who has those, they're very nuanced as to whether you would meet the criteria for a bulk billed scan with increased risk, or paying the $100 because of increased risk, even though the government won't pay for it. Bariatric surgery alone won't be one of those indicators, but it may be if we pull it all together with those other risk factors.
That's excellent to know. I think that bone health and these sorts of conversations are just not had enough.
Yeah,
at all across the board. We have a family history of osteoporosis. I do have celiac, and obviously I have had bariatric surgery. So I'm ticking all of those boxes. But I'm also extremely diligent when it comes to my supplementation and taking a calcium supplement because of all of those factors. Because I would like my bones to stay nice and healthy as I get older. Thank you very much.
Absolutely. It's an awful thing to have a hip fracture. It causes a lot of problems in our elderly, for sure.
Just wondering, if someone's on medications to help them with their, whatever they're going through with menopause, can those medications be affected because of of a weight loss surgery? Can it sort of affect our body's uptake?
Yeah, it can. It depends on how many months to years people are after their bariatric surgery and the type of bariatric surgery they've had. There's not a lot of evidence so they've done studies of certain medications so we can get an idea of the body's adaptation. So the body actually adapts quite well to bariatric surgery after that, 12 to 24 months with absorption of medication. But it's in those first months to years that there can be a variable absorption, so usually less absorption. But also it depends on whether that is, and I'm talking about oral medication there, but certainly from the hormonal treatments from a menopause point of view, there are a number of topical or local estrogen and progestogen replacements, which would have less of effect with someone with bariatric surgery. With the topical ones, you have gels and patches, and certainly there does seem to be individual variance in skin absorption there. So a lot of the prescription of menopause hormone treatment would be very individual, whether you had bariatric surgery or not, particularly from a topical point of view, being aware of potential absorption decreases depending on how malabsorptive the bariatric surgery was.
Goodness me. So very, very important to be in touch with your GP and just be very, very collaborative and working as a team to get through.
Yeah, I would like to say if people are wanting or finding it hard to find a GP who is up to date with the changes from a menopause management point of view, there is a website, which is the Australian Menopause Society website, and they've got Find an AMS Doctor, so that's Find an Australian Menopause Society Doctor. And so there's a website there which people can find a doctor who's part of the AMS Society and does menopause consultations. And on that website, you'll find GPs, you'll find endocrinologists, you'll find gynecologists. So if people are feeling as though their GP doesn't have that knowledge, and I'm not surprised because things have changed so much. It's very hard for GPs to keep up to date with.
Yeah, 100%.